Good morning, everybody. What a nice crowd today in the morning. I'm really delighted to welcome you to the session Prevention Better Than Cure, Enter Predictive Genomics, Harnessing the Genome to Innovate Prevention, supported by Thermo Scientific within the European Health Forum Gastein. I'm really grateful to Thermo Scientific that we can meet here today. I say hello also to all of you following us online. My name is Artur Olesch. I'm working as a digital health journalist, as a journalist focused on healthcare innovation, breakthrough innovations in healthcare. Yesterday we heard much about the European health data space. The WHO Regional Director for Europe, Hans Kluge, also mentioned the pandemic of non-communicable diseases. And I think it's the right time to start leveraging the power of predictive genomics in Europe to shift toward preventive healthcare. I guess nobody has doubts that the treatment-oriented healthcare that we have now is far from being perfect. And therefore, we are here to initiate the Predictive Genomics Moonshot. And I'm honored to co-moderate this session with Bogi Eliasson, whom I know for many years already, and I really admire what he is doing. Bogi is the Director of Health at the Copenhagen Institute for Future Studies. Among the many roles and projects he leads, I would highlight the Nordic Health Movement 2030. The movement advocates for a paradigm shift in healthcare based on the principle of allocating the equal healthcare spending on treatment and prevention. Fair, isn't it? So it's getting possible if we start smartly benefit from the latest innovation like digitalization, data, and we will learn today also predictive genomics. So Bogi, please come on the stage and introduce yourself and introduce what is this session about.
Yes, thank you so much. You can hear me, right? Good. Thank you, Artur. I do also admire your writing and your moderation, you know that, but we shouldn't just rub each other's shoulders. And we are very happy to have a very good panel with us today. So, as Artur said, we have been involved very much in the Nordics with focusing on how do we get to half of the budget spent on prevention. But this is also an advanced form of thinking, not just primary, but also secondary and tertiary prevention. So how do we keep people as healthy as possible for as long as possible? And as Artur mentioned, we have an epidemic of NCDs, non-communicable diseases, but we are also in a world where we have outlived the paradigm that really helped us lift people from the average lifespan of 30 years to reaching 80. So the standardized one-size-fits-all. We should still use basis of it, but it's not enough anymore. So what is happening now is that we see the fourth industrial revolution playing out. So that's data and digital structures. It's new biology or different kinds of biology, and it's new materials. But it's not those separated, it's merged. And that is what we are beginning to see, and that is what predictive genomics is a part of. So the new biology that I see it as the magnifying glass that the Human Genome Project gave us. But we have also learned that there are different levels here that we didn't dream about 20, 30 years ago. So we are also in a learning process on that part. And it is possible because we have more computing power and we have new smart materials, nanomaterials, new kinds of lenses that can make it possible to look. So what we see is a hyper-specialization and holistic connectivity, holistic thinking at the same time. And that is really challenging us because we don't have the frames to work in that way. So what we hope also to get out of this session is to say, okay, we have some technologies, some concepts, some usabilities that actually can deal with the biggest challenge we have today, that the health systems are not sustainable. They are breaking down. It's not a question about they might break down, they are breaking down. The avoidable disease burden is just growing, but there is another positive side to this. We see from the Copenhagen Institute and also with the Nordic health work, we see health as the most important societal pillar, not just for happiness and well-being, but also for growth. This is about deliberating potential resources in society by keeping people healthy as long as possible. We will still have illness. We will still have treatment, but we can go from 100% treatment to 50% treatment and rest on prevention to keep people as healthy as possible. So this is also where the polygenic risk score, pharmacogenomics, predictive genomics in different ways really sets the focus on we can actually do early detection, we can do prevention, and we can do early and precise intervention much better than we normally do today. But it's also something that can be scaled beyond the richest countries in the world, which I think is important. And before giving the word back to Arthur, there are different kinds of these things. I will just leave you with 2 questions or 2 statements. So remember that genomic is not an invention, it's a discovery. Even if you don't like it, it's still there. We brag of being knowledge societies, so we should embrace the knowledge that comes with it. One provocative question is, how many people did privacy kill because we didn't use the data when we should have? So with that, I think I will give the words back to Arthur.
Thank you very much, Bogi. Before I will give the floor to the panelists, I want to summarize very briefly what is this session about, so you profit the most from the 90 minutes with us. First of all, we will explain what predictive genomics is, so you will learn about some really fascinating research projects. Our expert will discuss how predictive genomics can be part of the innovative prevention of non-communicable diseases. Then we will try to find a way to implement predictive genomics in the national healthcare systems and policies, and also in the foundations of the European Health Union. And so in front of us are all these great benefits of predictive genomics, but of course, and it's the case with every innovation or technology, we have to address the risk and find a way to reduce them while amplifying the benefits. We have a great experts who will deliver the most up-to-date knowledge, but we also want to participate in this session actively. So Bogi will be the master of the ceremony, will lead the discussion, and I will guide you through the session. I will ask the questions from the audience. I will be a kind of link between audience and the panelists. So we have also prepared some polls on Slido. Please feel free to comment, report, share your thoughts on social media, on Twitter, on LinkedIn, on TikTok, on Facebook. And don't forget to use the hashtag EHFG, European Health Forum Gastein, and also Predictive Genomics. So everything is working now, so it's time for the opening presentation to set the stage. And I would like to introduce Andrea Gana, a group leader at the European Molecular Biology Laboratory, Institute for Molecular Medicine, Finland, and a research associate at Massachusetts General Hospital, Harvard Medical School. Andrea's research focus is on the intersection between epidemiology, genetics, and statistics. Andrea, the stage is yours.
Yes. Thank you.
Hi, everyone, and thank you for showing up to this session. Here we are. So I think we are all... I have disclosure. I was provided travel support by Thermo Fishers on this presentation. However, I was not provided with an honorarium fee, and I don't have any bells to disclose. Okay, so we are coming from a pandemic. We are emerging for it, and I think we are all brought back to reality that the number one killer in the world are actually non-communicable diseases. However, the good news is that these diseases are actually preventable, and the bad news is that we spend very little on trying to prevent these diseases. Around less than 3% of the EU budget is spent on these. There are many reasons why diseases happen and occur. One important is genetics. Around 1/4 of the disease risk can be explained by genetic factor. And genetic is sort of an untapped resource to try to understand and act upon prevention. For example, we can use genetics to identify individuals at high risk, and then we can inform these individuals. They might want to change their lifestyle, but we can also identify potential interventions on individuals at high risk to reduce their disease risk. So the Genome Project has been around 20 years ago. And from them, we have learned a lot of things. And we had spent quite a lot of time in the scientific world to study the association between genes and diseases. And probably the biggest surprise that came from these years of experiment is that there's no a single gene associated with common diseases, but that diseases are polygenic. So as the opposite of rare inherited disorder, common diseases such as diabetes, cardiovascular diseases, and cancer are actually characterized by the impact of hundreds, if not thousands, of genetic mutation across the genome, across many different genes. So when we speak about the genetic of this disease, we cannot consider a single genetic effect, but rather we should consider this polygenic effect. And how do we model this polygenic effect? We use this genetic score. This genetic score takes into account the combined genetic effect across the entire genome. And each of us has a different polygenic score for different diseases. Most people will be at the center of this distribution, so will have an average risk of a certain disease. But some people will be on increased risk, and some other will be on the decreased risk. So the key question is, given in the past year we have defined this polygenic score that are able to capture disease risk, can we use this genetic information to identify individuals at high risk for common diseases? And importantly, can we use this information to improve health outcomes? Now, showing you some results, this is a project that we have launched. It's an EU-supported project called Intervene. We started around a year and a half ago. It has a project that aims to put together genomics data across different European countries. We have combined more than 1.7 million genomes across Europe. And we have studied the association between this genetic score with 18 common diseases, which have a large impact on the health burden and disease burden in Europe. We can do that because all these genomes are linked to longitudinal health outcome, like electronic health record or registry data. So what I'm showing you here are disease trajectories. So you have lifetime risk of age. And each of us is on one of these trajectories. Now, most of the people will be in the central trajectory. And here I'm giving you an example for type 2 diabetes and breast cancer, two common diseases. Most of the people will be in the central trajectory there. And that means that by the time you are 50, you will have around 15% risk of developing type 2 diabetes. When you age to 80, that risk will be above 20%. This is the average individual. But then there are people in the top 1% of this genetic score, which seems like a small number, 1%, but it's actually more than 4.5 million European citizens. These people will have a risk for type 2 diabetes of almost 70% by the time they're 80. On the contrary, there will be a 1% of individuals that will be protected, or naturally, genetically protected from developing type 2 diabetes, and their risk is going to be below the 10%. So you can see how these genetic risk scores stratify the risk trajectory across the lifespan. Similar story for breast cancer. If you are on the top 1% of this genetic score, 1 out of 4 women will develop breast cancer by the time they're 80. But if you are in the bottom, it's only 1 in 33 women that will actually develop breast cancer. So I hope I been able to show, or maybe even convince you, that genetic scores are able to stratify disease risk. Now the question is, what's happened if we return this genetic information? Do people do something about it? And here is a study by my colleague, Elisabeth Viden, which has been returning genetic risk information or polygenic score for cardiovascular diseases together with established risk factors like cholesterol, blood pressure, to more than 7,000 individuals in Finland. these individuals were enrolled in the study, the information were provided, and then they were followed up after 1.5 years, where they were giving another blood sample, so the risk factor could be measured after 1.5 years. And there's been several questions that have been asked to these study participants. I think, importantly, the largest majority of these study participants believed that genetic factors were important to influence disease risk. So there was an understanding that genetic was important in impacting health risk and disease risk, at least for cardiovascular diseases. Importantly, the largest majority believe that they can impact their disease risk through lifestyle. So the genetic information was not seen as a deterministic information where people couldn't do anything about it and they will just, go out and live an unhealthy lifestyle, but actually was informative, and these people thought they could change their genetic risk. And in fact, 43% of individuals in the higher risk group took action to lower their risk. 21% visited a doctor, 14% quit smoking, and these effects were larger actually in those at higher genetic risk. So just to summarize, what are the advantages of using genetics for prevention or this polygenic score? Importantly, there are many biomarkers that are predictive of disease risk and many tests. The real advantage of genetic is just not to measure once in a lifetime. You don't need this repeat assessment. And once this genetic information are, for example, available to you or to the healthcare, that can be reused for multiple purposes. They're relatively low cost, especially if we do this polygenic score using a specific technology. A single test can be used to calculate polygenic score for multiple diseases. Your genome can be used to study the association with different diseases. And I just spoke about, the preventive application of this genetic score. There are many other applications. There's pharmacogenomic, disease prognosis. We start to discuss about using genetic score in trial design to target specific populations. So there's many other things that you can do once you have this data. There are important challenges with polygenic score, which shouldn't be sort of underplayed. Current polygenic score works well, or the result I show you are in individuals of white ancestry. They don't work so well in non-white ancestries. And so there is an important challenge of equitability of translation of these results for non-white ancestries. We are closing that gap. We are doing more and more studies in traditionally underrepresented population in genetics, but at this point there's still a gap. Polygenic score are not immutable. I mean, the measure of polygenic score, that your genome is immutable, but how we interpret with this data change over time. There is always new research, and so if we think about a practical implementation of this test in the healthcare, we need to think what to do if new information come on board. And then the genetic is not deterministic, meaning that this polygenic score, they interact with the environment. If we change the environment, the impact of this polygenic score on the disease risk might change. And so we need to think about that when we think about their implementation in the healthcare. And this is all from my side, but happy to discuss more later. Thank you.
Thank you very much, Andrea. Please join us on the stage already. And I think it's a great warm-up for the discussion. And now I would like to invite all the panelists onto the stage. Mark Smedler is a Senior Vice President and President in Genetic Sciences at Thermo Fisher Scientific. Please come onto the stage. Maxa Shabani, Assistant Professor in Health Privacy Law at the Faculty of Law and Criminology at Ghent University in Belgium. Maxa's research focuses on personal data protection, health privacy, data sharing, and data-driven biomedical research ethics. Tula Helander is a director of the Biotechnology and Medicines Unit at the Finnish Ministry of Social Affairs and Health. The unit handles issues pertaining pharmaceutical services, data protection, acquisition of vaccines, biobank law, genome law, medical research, and medical devices. She is a member state representative and co-chair with the Commission for the Declaration towards access to at least 1 million sequenced genomes in the EU by 2022, and member state representative at the subgroup on cancer, and of course, Bogi Eliasson as a moderator. But before I hand the discussion over to Bogi and our experts, we want to ask you a few questions on Slido. So please go to the slido.com, and can we have a screen with the Slido now? Yeah, and use the hashtag Luna, so you can use the Slido. Those of you who are following us online, you can find the Slido chapter directly on the conference website. So the first question is not a question. We would like to create a beautiful thought cloud. Is what is your first thought when you hear the term predictive genomics? What comes first into your head when you hear predictive genomics? Well, we have scary, but we are still waiting for the results. Of course, we will try to address these issues that we have on the screen, and I think the scary is quite popular right now and is understandable. We know that predictive genomics is an issue that we should discuss. It promises a lot, but of course there are also dangers that we have to address. Prevention, now slowly, you'll start to realize that prevention is also a very important part of the predictive genomics mission. Future better care, well, we will come back to the thought cloud later. And now let's have the second question. I'm really happy that the prevention is on the top right now. We started with scary, but now the prevention is in the center. Let's proceed to the second question, which is a multi-choice question. What are the biggest benefits of predictive genomics? So we have options like better insights into the patient's health, better prevention, lower cost of healthcare, new insights for the doctors, a chance to lower the prevalence of NCDs, the opportunity to conduct big data analysis for research purposes, and others. So better prevention wins from the beginning, and I'm really happy to see that. We will ask the same question at the end of the panel discussion, and we are really curious how you change your mind. So better prevention is still on the top of the list, better insights into the patient's health, of course, and a chance to lower the prevalence of NCDs. I'm really happy to see that on the third place. Lower cost of healthcare, we hope so. Okay, so we will come back to these questions at the end of the session. And the next question, the third question, is also a multi-choice question. What are your concerns related to predictive genomics? It's scary, we know already, but here the options are bigger inequalities, two-class society, false predictions leading to false measures or unnecessary fear of patients, rising costs related to DNA sequencing, low literacy around genomics in society that lowers its acceptance, and privacy concerns. Bigger inequalities, it's creating a two-class society, those probably who can afford the DNA test and those who can't. Then we have false predictions leading to false measures or unnecessary fear of patients. Our experts are following the results, and for sure we will address them during the panel discussion. So it's good to have the starting point for our panel today. And okay, so we stop now. And the third question, and the last one, is: would you consider doing a predictive genomics test yourself when your doctor could use it in prevention? not just for yourself, but for your doctor. Yes, genetic risk score to predict the risk of developing diseases. Yes, pharmacogenomics test to avoid adverse drug reaction and improve efficacy. Yes, both or no? Both, wow. So we have already convinced you to predictive genomics. But we won't stop at this point because we will go deeper into the topic of prevention, genomics, DNA tests, the promise, and of course, the risks. So with this yes, it's a great start for the discussion. Once again, please ask the questions on Slido. In the middle of the discussion, I will be back and I will address all the questions to the panelists so you have the chance to interact with our experts. Bogi, the floor is yours.
Thank you so much, and thank you for your interactivity. So now we are gonna go, Andrea will be having a silent mode because he already has talked. As an Italian does, right? Oh, you live in Finland? Ah. Yeah, but then you do all the talking because the Finns don't talk, right? Right, Tulla? So, but just to catch up, I think one of the main points, very important from you, Andrea, was from knowledge to action. And this is actually what is driving me personally very much, that we have at least half of the technology and concept we are not bringing into play. So that I think is very important to have in. But also to have in mind that lifestyle is something that can make us ill, but also keep us healthy or make us healthy again. The lower cost of healthcare, I also think, is something that should be advanced, and I think the panel will come a little bit in on it, because the cost should always be related to what do we get. And one of the questions that we also got here on how precise and how good is this, we often forget to compare to what we have. How precise is what we have? And we demand that what comes needs to be perfect. We see the same with self-driving cars. We don't accept any accidents with self-driving cars, but we do accept accidents with cars that we drive ourselves. So we should also have these things in mind when we think about risks. So now we're going to go to a short opening statement from Mark, Masha, and Tulla. And Masha, if you could start, and you have 3 minutes, and I need to be sharp with you on that one.
Sure. Can you hear me?
Yes.
That's great. Thanks, Bogi. I think I will start with a little bit of a challenge that we will be confronting with all these prediction in genomics. And I think this will push us to redefine some concepts that we are currently a little bit familiar with, that is related to standard of care. What are the roles and responsibilities of the involved parties in this story? So we have healthcare professionals that they can actually offer these tests in different stages of life. So we are thinking about from newborn to much in adults that this can be offered. But the question is, should they actually offer these tests? Because we already talked a little bit about the challenges. And also, on the other hand, the rights and responsibilities of the individuals and patients in terms of what they can actually do with this genetic data, and whether or not this impact their perceptions of what is being healthy.
Thank you so much. And before we go to a round of discussions and answers, Mark, I think you have worked a bit in this area.
Thank you, yes. So I come from the perspective of the already convinced, right? So I'll probably play that role as we move forward. As we understand genomics in people, there's between 1,200 to 1,500 genes that you either want on or find a way to turn on through environmental behavior, and about 24,000 you want to keep switched off. Right? That's kind of the broad understanding, and really what predictive genomics does is help you understand what are the environmental and behavioral factors to go turn those genes on or keep them turned on, or conversely to keep the other genes switched off. Right? The benefit for populations, in populations that have adopted this, and this is from the work we do around the world, but also the work we do with our own employee base. So Our goal is to lead the world in serving science. So we offer opportunities to our employees to opt in to these types of things because we think we have a responsibility to help them manage and improve their health. And in the work that we've done so far, we see those immediate benefits for them and their healthcare outcomes. And then also for us, we're self-insured around the world, so we pay our own healthcare costs in the countries in which private companies are allowed to go do that. And we see those immediate benefits, right? So we found on the micro scale ways in which to go engage in conversations that lead to super productive outcomes. We work with customer groups around the world that are going through that process and engaging to create those productive outcomes. And really the point of showing up here is to help engage in the conversation to make it less scary, to make it more well understood, and then to go figure out what do we do to go foster the adoption across the community, right? Given that there are a series of challenges which we'll get into as we progress.
Very good. Thank you. And from the genomic core of the North, Tulla?
Thank you. May I start by, there was the first question, what there was those words about scary, unknown. I must raise one of the reports, policy paper, which we made by the heavy support from the European Observatory. I don't know if Joseph is here, so that it was the regulating unknown. So that this is just a question, regulating unknown. So that I think that the information and this kind of a discussion are very important. So that I do hope that we are in a way, because there is a momentum, that we are in a turning point. And I just wrote, I quote one text. I just read it, that it goes right. But it's, I think it's very familiar if you think about it. The text goes that health is a physical balance, and that diseases are the result of disruption of this balance. And correcting the imbalance, on the other hand, is very individual, and that all treatment do not work equally for all people. Okay, but this text is over 1,000 years ago written. It's from the Handbook of Medicine's Theoretische Pantechnie. If you can imagine, it's a medieval from the medieval medical textbook. So that and it was sharing the best practices, because it was later because it was the text of its time of the Islamic world. And it was later given a similar status in the first medical schools and universities in Europe, so that it raised in the level of medicine in Europe. So, and I was in a way amazed that these individual, these personalized things are already. So are we really? Everything is invented already, so we just have to implement it, isn't it so? So, but just today, now we are saying that we are in the turning point. We are in the era of new medicine, personalized medicine, precision medicine, individualized medicine, many nicknames for our loving child. So that, but are we really ready for this? So I mean that we need the discussions, and if we think about where we, or let's say where I come from the ministry. So what about the legislation? Does that really support this kind of a personalized medicine, precision medicine? And what do we need that we can really enhance, or let's say we can tailor not only the treatment, because as we know, there are hospitals, they are not health institutes as they should. So we should shift from the treatment to the prevention. Thank you.
Yes. Thank you so much, Tulla. I think, yeah, we call them also sick houses, Krankenhaus, all these things. So can we shift from the sick care to the health? But that's not necessarily health care, that's health, right? There's a distinction there. So now, going to before I go to the opening questions to all of you, where Andrea is allowed to join us again. I think it's, just let me mention that I worked in the space for more than 20 years. I started the first population genome approach in my native Faroes. So I've been in a lot of these discussions that we now see in predictive genomics, just with different kinds of genomics as well, but also on thinking how do you serve a society in it. So if we start with you, Andrea, just very, very short. I mean, you have been in on these things, but just a very short tagline on what is predictive genomics for you. So just to, if we can give the audience a tagline on it.
Well, predictive genomics is, using genomic information to identify people that are on the different disease risk spectrum and, better target them if it's possible.
Mm-hmm. Okay, very good. Masha?
Same
Yeah,
question.
go ahead.
Well, I think also for me, it refers to somehow empowering the patients and individuals with giving them some information in different stages of life that can help them in their changing their lifestyle or decision makings during the life. So in principle, this should be something that can empower them as well with this knowledge and information.
Okay, good. Mark?
So I think it's an additional tool. It's complementary to traditional health practices, and it can work in two ways. One is the kind of longer-term prevention view, so that's the polygenic risk score, in which you have an understanding of the behavioral environmental factors that could influence the rest of your life. And then also from an interventional or a treatment perspective with pharmacogenomics, making sure you're taking the right dose of the right product for whatever disease state you're trying to treat. Those used in combination give you both a relatively quicker impact and benefit, but also a sustainable long-term benefit and impact as well.
Okay, thank you. Tola?
I think, well, I do hope that this is empowering people, so that they see the data. They see that they have the responsibility, but they have the right to see the data. And not only the data, but integrating the data. As we know, the data is the new oil. So that how to really combine the data and for the better outcomes, the quality of life.
Thank you. So if there are any questions, please just raise your hand or scream or do something so I notice you. Everything is very clear? You're all convinced? Okay, there's one here. There's one on the back afterwards.
Thank you. Magda Rosenmüller, Jesse Business School. I actually had put it in the Slido, but happy to ask. I'd like to have your opinion that should we do polygenic testing for newborns, for all newborns? And, well, we have to decide which of the polygenic, but we might identify the most important one. Would that be something that you would recommend of doing across the European health systems?
And just to take the last part there, was there a question, should that be a European frame, or would you like to have it in the national frames as we know today? Okay. I don't know if, okay. Tola, would you start?
Well, that is it's a challenging question. So that, well, at the moment, in our country, that's not possible. So, but I think that that must be discussed, of course, because well, I'm a piloting person, so I think that we need a pilots. Well, if you think about from the legislation perspective, there are always challenges, but what are the goals? So I think that that's why we need the goals, so that what are those we are really want to achieve? It's very difficult when you are the newborns.
Yes. Do your others want to respond on that one?
Just to mention briefly that from the regulation perspective, of course, in the national level, we have quite a restrictive framework for testing on children. It's been always historically a discussion that what should be actually communicated to the parents. If you're talking about, for example, late onset conditions, is it actually useful to communicate this to when it's just a newborn, these discussions about right to open future for the children and so on. So I think that it would be very challenging, at least from the regulatory perspective on national level, to be able to justify that what should be actually the scope of such polygenic risk score calculations for the newborns?
Yeah, well, my answer is definitely yes. Might be biased, but so it's not science fiction. UK has just launched a pilot on that, so people are doing that. It's not only something that it's valuable now. It's an investment for the future. In two ways. First, is an investment for the individuals because this genomic data will stick around and they can be reused in the future. It's an investment for science because this data can be used by scientists to discover new advantages. The key, clearly there is the legislative key, which I'm not going to touch. There is an infrastructure key, the infrastructure question. And I mean, my sense is that law can be written, relatively fast. But building an infrastructure to support a country, I see some doubts there, but building an infrastructure to support, for example, from a country where 5 million people, but our friends, 60 million people, genome, it's a huge infrastructural challenge that we should probably start to tackle now, because in case someone will finally decide it's time to do it, then we will have to solve those problems. And so.
Mm-hmm. Yes, Mark?
I would say you can, but it's not where I would start. So generally, if you go look at behavioral adoption of folks that use polygenic risk scores, starting with someone that actually presents with a condition or has a concern, goes to a doctor, wants to understand about the cholesterol, diabetes, something like that, you have a much greater uptake of them actually absorbing the information and then making the positive change towards prevention. So the immediate return or the immediacy of the improvement of health is greater. From a research perspective, I agree with Andrea that starting to build a database that will expand over time to help inform how we manage human health, I think is hugely beneficial, right? But I look at that as more of a secondary or more evolving as opposed to a immediately applicable.
Mm-hmm. Good. We have a couple of marked questions, and we also have something online. Arthur, do you want to take one first, or should I take?
Let's take the question from the
there was
audience.
one in the back in the beginning. I have no idea who was first. I'm almost blind, so I'm excused.
Hi there, David Barron from the UK. Interesting that you mentioned about the pilot in the UK. I think on average it takes about 20 to 25 years for a new innovation to be spread right across the NHS. So it does take time. I'd just be interested for views from the panel around what is in their view, the biggest implementation challenge for this, and how would healthcare systems overcome those implementation challenges? Thank you.
Well, that was my next question, so that was very fortunate. So now we save time on that one. So yeah, and I think the one of the things we really want to have on the agenda here is, okay, we have the technology, we have knowledge, we will always want more knowledge, but how do we get this applied? Who wants to start?
I'm happy to go lead the charge. So from an implementation perspective, I'd say the first one comes around scale and data, right? So scale, the N, as referenced by Andreas, the 1.7 million genomes loaded in to go develop the polygenic risk scores, is super important. In order to do that, you need the transmissibility and the aggregation of data, and doing that across national and international borders is challenging. Also, the interaction of the people whose data it is, and having them engage in that topic and consent to moving forward with it is also not universal. So when you start to go figure out, when you have data, how do you then actually interrogate that data over time and develop the conclusions? The secondary pieces of actually doing the work, so doing the genotyping, developing a risk profile, is mostly solved at scale. There's plenty of capability and capacity around the world. The last part I'd look at is education. So it's educating the healthcare system, the nurses, the doctors. If you're 10 years out of medical school, whatever education you had on genetics is massively out of date, right? And if you go look at the population of doctors that treat, actually most of them are more than 10 years out of medical school. So there's a huge amount of work to be done for education in the healthcare community. In addition to, if I go look at scary as being one of the topics, education in the patient community as well.
Thank you for the blueprint. What is the biggest obstacle? Why are we not there?
Again, the lens that I take, Where we found adoption to happen very quickly is when the payer for the test is linked right next to the person that benefits from the economics provided by the test or the reduction of healthcare costs. And where that happens, those two are very close, adoption is very quick. Right? If you separate that by different ministries or different ministries in different geographies, finding a way to go build the loop of here's an investment in prevention and actually capturing the benefit of that prevention, the more complicated that loop, the more time it takes.
Good. Andrea, it looks like you have an opinion here.
Yeah, I will try to be brief. I think there are two main challenges in implementation. The first is how do you actually implement in the healthcare with the electronic health records and the system. And I think to do that, you need an external body. So you need an you cannot imagine to have your genome implemented in the different healthcare electronic health record system across hospital. You need to have something new, something external. The second challenge, which I think it's more important, is what you return to the patient. I mean, if you speak with clinical geneticists, they will not report many information if they're not actionable. So that, I think, it's a is a medical challenge that needs to be faced.
Thank you.
I think for me, the part about interpretation of the results and the fact that this is indeed very dynamic, it's not very static, the interpretation that's being done on data. And this is already raised a lot of questions about the duty of the healthcare professionals in terms of reinterpretation of the results, whose responsibility is that really to follow up on that. And it comes as well next the how we can actually involve patients in this story as well. Should they actually ask for this reinterpretation, for example? How can they be, make this even more participatory, of course?
So actually including the person in personalized health, which might be the... Tula?
Well, I think just the financing. So how we translate these benefits to economics, so that it's really it's the other, well, the payers, not only the taxpayers, but especially the Ministry of Economics sees that this is worth investing. So I think that is one of the challenges. Other one is we can't lose people's trust.
No.
So that is very important. At the moment, luckily in the Nordics, people are happily participating to clinical trials. They trust research, and they are trusting authorities. They want to be along, but along to in the development. They want to develop services. But as we do know, there is not too much. As it was scary, so that we should treasure that. So that in every aspect, I think that we have to treasure the people's trust.
Constructive criticism. Arthur, do you have some questions you wanted to?
Yeah, we have a lot of questions from the audience, and I picked up four ones. The first one would be probably for Andrea. What is the difference between genetics and epigenetics? That's the first one. I think that we should clear this misunderstanding to develop prevention. The second one is, under which conditions would genomic exploration of the patient be done, with which indications given? And the third one, while predictive genomics might have the potential to prevent a large % of disease, how do we make sure it does not overshadow the importance of promoting healthy environment, healthy behaviors, which arguably would be more important influencing factors? So maybe let's start with the first question. What is the difference between genetics and epigenetics to develop prevention?
Yeah, so I know epigenetic in the scientific field is used with a very narrow meaning. In the general field, is used on everything that is not genetics, for what I understand. I will call epigenetic environment, if it's possible. In practice, is some methylation on your DNA, and if you smoke a lot, you can see that as a methylation in your DNA, actually. So you can build very good predictors if you smoke or not by just looking at some things on your DNA. So that's epigenetic, but mostly I will try to conceptualize as the environmental influence on your health.
Thank you. And under which conditions would a genomic exploration of the patient be done? With which indications given? Who would like to answer this question? It seems to be a very hard question. Maybe Mark.
Well, I'd go back to the work that Andrea showed earlier, right? That the 18 common or most common kind of disease states, again, is a good starting place, right? So for the work that we go look at in terms of the practical application as opposed to the research application, which is generally broader screening, if you can manage across a population group hypercholesterolemia, you can manage diabetes, and to some extent, you can provide appropriate mental health, then you've managed a large portion of the, things that lead to healthcare expense or time away from work, et cetera. So there's, a relatively small focused area that you can go target where you can get immediate benefit. And then as you gain more data over time, obviously you can expand that out. But you can be, relatively targeted, right? There's an interesting question there about, I need something immediate, so I understand my own polygenic risk score. I have a very low risk for hypercholesterolemia, much higher risk for diabetes, right? So the conversation with the genetic counselor is, bacon is fine, sugar in your coffee, really bad, right? And it's as simple as that. That's the lifestyle change in terms of what I need to go do in order to go manage my risk.
Thank you. We have a question on the screen. Why was predictive genomics not picked up before? Is it really a major health tech? But I would like to ask Tula a question about the future. What kind of framework, legal framework, do we need on the European level to make predictive genetics more important? So are there some steps planned already? We had the project towards 1 million sequenced genomes by 2022. We have 2022 right now. So what comes next?
Thank you. Yeah, I think as we do know, the whole thing is so challenging that no institute, no country can cope this alone. So that's why I think it's great that we have this initiative, that 1 million genomes. And more of that, I really acknowledge that there is a 3 DGs. It's chaired by Connect, but there are RTD and there is Sante as well, so that we can really look at more largely. So that 1 million genomes, yeah, it was at least 1 million, but it already, when we started in 2018, we said that, well, it was very, well, low number, as we knew already then that we have the 500,000 genomes in the FinGen, even though they are not really genomic, but we have already collected quite a bunch of that. But I think we need pilots, we need concrete actions, and the 1 million genomes it started from the research, which of course as it usually does, but then it's now shifting towards the healthcare, and I think it's very important pillar for the European Health Data Space Initiative or legislation, because it needs concrete actions. And we have many rehearsals already with the member states assigning the signatory states, all together 23. So that very important discussion we have. So that we need good pilots, concrete actions, and if I may add, I think the key is that there are 4 use cases. Cancer, infectious diseases, particularly COVID-19, and non-communicable diseases. There are more public diseases, let's say, and then rare diseases. So there are 4 use cases, so we can really pilot and show what is the power of genomics. And so that we do need these kind of rehearsals where we all together we are on the same table and discuss the challenges, but the opportunities there are.
We have also a lot of questions about ethical issues, about transparency, about data protection, and it's a great question for you. Let me find it right now because I lost it. Without a safe data protection framework, no predictive genomics are ethical to pursue. How do we go about that as EU, Masa? Maybe it's a question for you.
I think that data protection issues in the context of predictive genetics, it's different in terms of the setting that we are talking about. I think that we are talking about research, which would be, of course, the legal basis for such data processing would be different when we are talking about offering this test already in the implementation phase in clinics for, let's say, under the healthcare purposes. So these are all different settings that which, of course, we have a different regulatory framework already. We know that what we have from the data protection regulation, from the GDPR, we knew that already genomic and genetic data has been considered as sensitive data. We have higher protections for this under the GDPR. But of course, we know that currently we are, of course, waiting for the new, more specific regulations, the sector-specific regulations from the European health data space, which is, of course, its coverage is quite broad because it has implications both for the primary purposes and also for the secondary uses, which could be for the in the research context. I think that the issues are, of course, also different. For me, when we are talking about transparency, especially in the context of implementation, I think it's really important to be able to communicate and give enough information to the patients about the limitations of these tests, because I think we heard from Andrea as well that so these tests have very serious limitations if you are not from European ancestry, you are not descendant from the European ancestry. So these are, of course, limitations that we need to clearly explain them to the patients. In the context of research and how these data are being collected and being, of course, processed in the context of research, and we know that there is a very great and big interest from the research community to further process this data for many different research purposes. So we call it under the data sharing scheme, of course. And we know already that this is raised also a lot of questions about so whether or not patients should be, how we should actually communicate this information, that this data will be further used for other research purposes, whether or not they will also benefit from the results. Because basically, if we call this purely research setting, then we have also in terms of the responsibilities of the researchers, we don't talk that much about return of the results to these patients. And I think maybe the one other aspect that I think that's also very important, which is the how these data are being also controlled by the individuals in a way that they feel their privacy rights are being respected and protected. And we know that we talk a lot about the organizational measures that should be in place, the responsibilities of the institutions to make sure that these databases are secure, enough safeguards are in place. But we hear more and more that patients also want to play an active role in this data management. They want to know that how their data are being used, and also ideally to be able to have an option to just opt out or withdraw depending on the consent model that we have. So it's a complex ecosystem, I would say, because we are actually dealing with a life cycle of genetic data from the moment that's been started, it's been collected for, let's say, research for development of the test, to the moment that you are actually implementing them and communicating them in the context of healthcare.
Thank you.
Yes. Thank you so much. And I also think this also highlights very much on that one of the changes that we are seeing is not technical, but more humanizing health by including the person in their own health side of life, which is a different we have seen for very much the last 5 years, but also going a bit further back. And I would just remind one more time in that we should be a bit careful of what we often do with new technology to demand that it should be perfect before we start, but what we have is imperfect and that's okay. And I think that's something we need to be really careful with, Because when we look at the flaws that we have in the one-size-fits-all system we have today, there are things which we clearly can help with the technology and concepts that we have, but we are prohibited because we want the perfection before we can start. So there was a question somewhere here. Maybe that's already answered? Yeah, you have one, yeah? There is a running microphone. A human-machine interface with a microphone.
Thanks a lot. So my name is Carmen Laplace, and I work in DG Research in the European Commission. And actually, first of all, I would like to thank you for the organization of this session. Personalized prevention is really close to our heart, and we are funding a lot of research on that. I would invite you to collaborate with our new coordination and support action that is trying to precisely build a roadmap for personalized prevention. But I would like to come back to the pharmacogenomics because we are talking a lot about potential problems from an ethic perspective and having right to information where we cannot act, and I can fully understand that there are things to be discussed. But when we look at pharmacogenomics, there we have the knowledge, we have the evidence, and it is hard to understand that people still are dying or suffering really adverse problems because of the fact that pharmacogenomics is not used. I mean, it's not 20 years, it's almost 50 years since this development discoveries started. So as now we are currently working with most of European member states and some additional countries associated to Horizon Europe in co-fund on personalized medicine, quite important instrument, a partnership that will start at the end of next year. We are currently developing the research and innovation agenda of this partnership for 7 years. I would be very interested in having your views on how we can accelerate the uptake of this. Because even when, I mean, in some regions, pharmacogenomics approaches are already implemented, providing incredible benefits, but how is possible that this is not upscale? What can we do? What would be your advice to us in order to support that uptake of personalized approaches?
So now I think the question, if I can rephrase it, not what is the biggest blocker, but what is the needed enabler so we get going. Tola, you want to start?
Yeah, that is a very, very good question because we need the pilots, as we know. But in Finland, we have, at the moment, we have the genome law at the parliament, and we have updated our genome strategy. And because we noticed that as there is plenty of studies and results, but nobody really took the coordination role, so that nobody really collected the data and the people together. And so we raised that is one of the pilots that we have to raise. Even it's horrible to say pilot because, as you said, we should have it already. But we noticed that nobody really took that in their hands or responsibilities. And now we really are hoping for that. Now that is one of the steps that nationally we can do that.
Yes, thank you. Mark, it looks like you want to say something.
Yeah, I'd just come back to the point I made earlier around connecting the economics. So, from a pharmacogenetics perspective, the scientific proof point, can we measure the variant? Done, right? The medical proof point, can we associate the variant with a disease state? And then can we understand therapy selection based on that? Done. The last one is the economic proof point, which is, do those first two scale, and is that scale a benefit overall? And the challenge is, while you have pockets of scale, they're disparate. They're in different places around the world, right? You're giving an example of the Teachers Union of Kentucky. Kentucky is one of the lower healthcare spend states in the U.S. Generally has lower scores across all of its healthcare. So the teachers and Teachers Union decided they want to go do something about it with their target population. They started running a pharmacogenomics program for the 36,000 people. Within the first year, they reduced their healthcare costs by 15% and improved their healthcare outcomes, generally from reduction of what we call polypharmacy. So these are people that have severe disease states. They take between 7 and 10 different prescription medications.
Yeah.
And just understanding the interaction of all of those together, so you start to reduce the number they take, the number of interactions, healthcare improves. But it's got sufficient N and I could go around the world with these pockets, but no one's collected them all together and provided the economic argument to the folks that actually, again, given the folks that generally have to pay for the investment up front, are separated from the ones that achieve the benefit. And then, there's always a time frame, right? So this is one of those ones in which you may not achieve the benefit for a year, which, leaves that person or the group that's made the investment having to then go defend why they've spent on something that's not immediately provable.
Very good. So we need a collection of the best practices and make a cost-benefit analysis around that, as I hear it. Masha? No, you? Okay. So I think there was another question somewhere down there, but it may be already answered. Okay. I have several questions, so no problem with that. One of the things going to, I need to look at how much time we have left. Andrea, you alluded a little bit to it, but if just to make it very clear to the public here, is predictive genomics mature? Do we need more evidence, or should we really push forward fast?
So from a technical standpoint, I think it's pretty mature. As a very low measurement error, you can make the same measurement of a polygeny score in multiple individuals and will work very, very well, almost like, cholesterol or other established measure. If you speak with a medical doctor, maybe that's, I don't know, many MDs are in the room. The point is that every disease has a different set of risk factors that are traditionally used in prevention for that disease. Breast cancer will have mammography screen, cardiovascular will have cholesterol. So what we are proposing is a little bit disruptive because it will be the same test across multiple diseases. And what a lot of medical society want to see is how much this test will add on top of the existing screening tool that are available for that diseases. So that type of endeavor is done, but probably is not as mature as it should be. So it's not enough to show genomics is great to predict diseases. We need to show that predict better on whatever is in existing clinical care. So that's maybe the part that still need a little bit of work.
But we can still start.
Yeah.
Yes. Masha, very concretely, do you agree or disagree, and also why the ethical risks associated with predictive genomics are manageable?
Well, I think I would say it's manageable in a sense that if we dedicate ourselves to, first of all, have a good identification of the issues, to be able to, as I said, offering predictive genetic testing in different stages of life, it's just generating different set of ethical issues. So I think we cannot really just have a very general rule to say that, well, this should be always offered or for all conditions. Just also a little bit related to the infrastructure as well, because in a sense that you are giving priority to a test and in a sense you are not giving priority to another test.
Yes.
If you are just being covered as well with public resources. So in a sense, I think what probably is important to just be able to have a good understanding, first of all, that what are the interests, what is at stake, because, for example, if I take the example of newborn screening, we are talking about, of course, we are just offering some information about the health of the child that not really can decide about it him or herself. So in a sense that you are having parents that they can decide about, how much information to be revealed. And sometimes these interests and rights are, of course, conflicting or contesting. So you have to really,
You are putting me into a dilemma. So I've been fully sequenced twice and given it to research without asking my kids. I've actually sequenced my kids. So my wife is from Peru, I'm from the Faroe Islands, and there is an old ancestor on my wife's side which is from China, which could actually be seen, which was quite interesting. I didn't know about it, so I went to my wife and said, what's happening here? But this is knowledge that we would need to deal with in many ways. Mark, if I can have you to be very concrete on, if you advise a government in an imaginary country to invest in predictive genomics at the population scale, what is the one priority? Not all of it, just one. What is the most important?
I would start with the pharmacogenomics, and I would start with delivering on a relative time scale, immediate improvement in reduction of cost at better or same healthcare outcome.
Mm-hmm. Okay, very good, very concrete. That should be easy to apply. No? And Tola, we need you to help us with providing that enabling. So what changes to the regulatory and digital health panoramas do we need to see to be implemented to predictive genomics? And is there a perception issue with the way health data is handled in Europe today? So of course data and the biology are interconnected. We can't separate that one.
Well, first of all, we have to have the vision, as
Yes.
we a little bit we have talked about. Vision, what is the road? Where are we aiming? What is the goal? What is the aim?
Mm.
So that is the first thing. So that, and we shouldn't, or are we afraid of the challenges or the risk there are? I think we should, on the contrary, use all the imagination, what could be the risks, and then we are very fully prepared where we are listed and we have been discussed about the risks. So I think we shouldn't be afraid of that. So that at the moment, I do hope, even I do know that it's always ministry's fault and too much regulated and too complicated legislation and everything. I do hope that the legislation that stands time in a way that it's not, shouldn't be that detailed. And as we do know, it takes a lot from the authorities and the other stakeholders to interpret the legislation. It's not us, so we don't see the cases, what is on the field. So I think they should be encouraged, so that what is the spirit of the legislation? We should trust to each other if we have the same vision. So that where are we aiming at? Maybe this is a very high level statement, but that is what it's all about.
So I'll give you an example of fantasy. When we started to work in the Faroes, we had a challenge because the legal frames didn't really include genomics. Genetics was in, but genomics was not. So we applied an interpretation that it was a digital copy of the blood, which is not a lie. Okay, then let's take a round. We don't have that much time together. So a country, now we play in scenarios, let's call it Genome Land, has decided that predictive genomics is good for the citizens. Who pays? Yeah, you want to start?
Well, I think that first we need that if it's cost effective and there is a national guidelines, well, taxpayers' business, so in Finland at least, so that I think if it's beneficial, I think it's from the public money. Of course, I can imagine already that there are diagnoses that the people would like to see. That's another thing. But if it's a beneficial for the prevention of the diseases, I think that is the
But
key.
that would be very easy in the Nordic or the
That is
full
true.
public
That is
systems,
true.
UK. It might be a little bit more complicated in mixed systems.
True.
Yeah. Mark?
I think it depends on where Genome Land is, right? Because I could give you 3 examples of a government should pay, it will get the benefit and reduction.
Mm-hmm.
A company, an insurance company, should pay, it will achieve the reduction in its costs. I could also make the case that the individual should pay.
Mm-hmm.
Right? I mean, you go look at, for those folks that have done ancestry, or for those folks that have pets and have genotyped your dog to figure out what breed it is, right? It actually costs less to go run your own polygenic risk score than it does to genotype your dog.
Yeah.
So, the people often access genetic information, what I'd call entertainment. You can access the same thing for your own healthcare, and if you go ask somebody, look, if you could find a way to understand your risks and mitigate them, is that worth $50 to $100, right? I do understand that that does start to segment society, and that's not universally accessible, but there is a large portion of the population that would start at yes, right? And if you want to democratize anything or make it available to all, first you have to go make it available to some at scale, and then it's a question of then providing that scale more universally, right? So, you know, democratization is always the end goal of making it available to all, but you got to start somewhere.
Very good. Masha?
I want to say, well, government can pay for it, but the consequence would be that it will be also strictly regulated. So I think this is a kind of like a trade-off that I see in the different contexts as well. When the government is paying for it or reimbursing it, it's very strict in terms of what should be in the scope of the test, how data should be handled, you know, raw data should be returned or not. So yeah, it comes with a trade-off.
I think that's also a broader question of should you allow for private choices for health where you have public systems or not. So I think this is more than just this part, right?
Yeah, definitely. I think that it's just a good example is in the context of direct-to-consumer genetic testing, you know, this DTC, which is in Europe, didn't really receive well, I think. It's just cultural as well. But besides that, even in some countries in France, they even banned it. So it was kind of like a choice of the citizens, but for other reasons, the government decided not to even allow that these citizens to pay for it, to buy it.
Thank you. Andrea?
I would try to be provocative, but I can imagine a couple of pharma companies that would pay for it, honestly. In Finland, we have a fantastic public-private collaboration where they pay for a genotype of 500,000 people. There is an enormous interest from pharma company for genetic data to
Could I just help
enable
in audience to understand that the FinGen project is very specific because there is a collaboration between the government and how many? 10 companies? There's a lot of international companies in it. So I don't think there's a different case in the world on that.
But, you know, many companies are interested in genetic data as well, yeah.
Okay, very good. So we had this question before on the European Union. So what is the role of the European Union, or what role can the European Union play in advancing predictive genomics? Is it at a country level? So we are in Europe now. This is the European Health Forum. And Tuula, I guess you are one of the drivers.
Of course, I see it very crucial, the role for the whole Europe and globally, because said many times, you can see that as well as a pilot for globally use. So that I think that because if you think about all the opportunities there are, I think that because, as I said already, so because no one institute or country can cope with it, so we do need the broad, conversations and discussions, but as well the legislation. If you are moving to another country, or let's say you like to share your data. If you think about all the diseases are now divided into subgroups more and more. So that it's even more difficult to, for example, to do the clinical trials, or let's say to study, so that we need not only 1 million genomes, we need more, but we need the pilots along the way. And I think that the role of Commission is great in coordination and raising the issues in EU level, and financing, supporting member states, and raising the knowledge. I think the very key is the raising the knowledge, because I see it in the Nordics what happened when we signed the declaration.
Yes.
So that it's really beneficial.
Okay, good. And now for the last round before we go back to the poll. And Arthur. You got 1 minute each. Are you confident that predictive genomics would be an integral part of healthcare in the future? So yes or no, and respond why. Andrea?
Yes. Yes, I think it's, the data are clear.
Oh, that was very clear.
I would say yes as well, because we just see the benefits of all these data-driven technologies, and I think this is one rich source of information.
And we will solve the ethical challenges on the way?
Hopefully.
Or, I don't know if there are challenges, they are at least blockers in some way?
Yeah, definitely. But, I mean, if we pay attention, at least, I think that's the first good start.
Mark?
So I'm an optimist, but it stretches my optimism to say yes. Right? There's a lot of work that has to be done to go take what has been done at, like moderate scale and go scale it across continents. And, that's a time and energy. So do we have the time? We'd like to take less of it. Do we have the energy? We have lots of it, right? So again, from an optimistic perspective, yes, but there's certainly a lot of work to be done to get it to go work at scale and for it to be democratized, to be available around the world.
So what you're saying is that we need to start early to prevent, so we live longer, so we have time to do it. Yes, okay, I got it. Tula?
Well, sure, yes. Definitely yes. Well, the personalized medicine is already here, as we know, so that we need the concrete actions. We have to, everybody wants to be encouraged and be empowered, and now we can share the data for us all, benefiting us all, so that I do see the light in a way, but I sure in a way I miss the vision that we could have a mutual vision that this is the way we should go, and so that and then we have those, as we know, we have to proceed stepwise, so that we have concrete actions where we can show for the politicians and for the financiers that this is the way to do it. So that definitely.
Thank you. So just to wrap up before Arthur asks you the questions again. So I think what we hear on the panel is that this is a valuable approach to go forward. Of course, there are some concerns that we need to deal with, but that is always the case when we do move forward, because we go into uncharted land. And I normally use this way from Kennedy, from Harvard Kennedy School, where you have technical change or adaptive change, or some call it the clock and the cloud. Adaptive change is when when you work with the known and you just adapt it or improve it a little bit. You have a blueprint, you know what to do. But the cloud or the adaptive change is when you really need to do something totally different and you don't have a blueprint. And that's what is very hard for our systems to grasp, because we want to have ticking boxes for everything. And that's impossible when we are building the tracks while we are driving. And just to respond to, I guess there were some comments to my unethical sequencing of my kids. I would just say that genomic information is something that's there. So somebody could just take a hair off my back and sequence it, and it would be there. So it's much more accessible than you think. So to treat it like something totally secret, I think is much more dangerous than not. So Arthur?
Thank you very much, Bogi. We have much more questions on Slido, but we don't have time to answer them. But I would like to comment on what is happening on Twitter right now, because people are commenting on trust, because we know that predictive genetics works. We have evidence, we have tools, we have technology, but there is the one missing element, that is trust. And I have a short question to all of you, like a sum up. What measures would you suggest to inspire trust in predictive genomics? Just one sentence, each of you. Tula, maybe you will start.
Well, difficult, just one sentence. Well, I think that, as I told, that the trust is the key. So that I think that we need the discussion with I think it's very beneficial that we have these patient advisory boards and citizen advisory boards involved, so that we can really discuss about the risks and show the opportunities. And of course, we do know that there are still challenges which are unsolved, but we shouldn't be afraid of that. We are in the right track.
Thank you. Mark, what's your opinion?
So having seen the Slido questions come up, it's been fascinating, and I'm super appreciative for all those that have asked the questions. To me, 2/3 of them fall under the don't have enough information, and 1/3 fall under the have somewhat of an opinion, right? So look, to build trust, I would start with the continued discourse and create a much broader understanding, right? How do you actually, what needs to be sequenced? Where does it need to be sequenced? How deep does the sequencing need to be? How does that information get used practically from a research perspective? How do patients consent for individual use, for long-term use, to be recontacted, right? There are, I think, well-established answers for all of those, but those answers aren't universally known, so that's part of the education that has to be done in order to go engender and then continue that trust in the community.
So we need improvements in predictive genomics literacy. Masa.
I think just also related to that transparency and trying to protect and respect the right to information of the patients. I think it's pretty much what you said already, that in different layers and steps of offering the test, development of the test, be transparent about the limitations and why this can be beneficial for the patients. So I think that this will help them as well to have also to have a good understanding of the limitations as well.
Andrea.
Well, we need to return information to people, and that's how we build the trust with them. And you know, if you ever took a recreational genomic test like 23andMe, you see the amazing work that they do to explain exactly how these things work. And it shouldn't be a company; it should be, the healthcare to try to do that and engage patient with this type of communication.
Thank you very much. To sum up the session, we proceed to the Slido right now, and we would like to have your opinion once again in regard to the biggest potential of predictive genomics. So the same question as at the beginning: what is the biggest potential of predictive genomics? What's your opinion? We will see if you have changed your mind. It was better prevention at the beginning, and it is better prevention right now. I think that's the right answer. Better insights into the patient's health and a chance to lower the prevalence of NCDs. All these free benefits, I think that everybody's agree, are the key when we talk about predictive genomics. The second question, should the European Union invest more in predictive genomics? Yes, it's necessary right now. Yes, in the upcoming 2-3 years. Yes, in 3 and more years. I don't know, or just no. Well, I think that we have convinced you that we really need to invest in predictive genomics. So nothing to add. It's necessary now. I think it's a good message for all of you, also the representatives from the European Commission and from the national authorities. And the last question before we close the session: how do you envision healthcare in the future? Prevention will be at the center of healthcare. Doctors will become architects of health thanks to predictive genomics. 50% of health spending will be invested in prevention and 50% in the treatment, Nordic Health 2030 vision. And every patient will have their own personalized AI-driven health advisor to stay healthy. Let's see what's the moonshot. Well, so every patient will have their own personalized AI-driven health advisor to stay healthy. Of course, AI-driven tools based on the data, also including DNA tests. Well, and 50% of health spending will be invested in prevention and 50% in treatment. that's a good news also.
It is. It is. That's the way we need to go. I think I'm biased, but being biased is just having an opinion, isn't it?
Okay, thank you very much. I think our experts deserved big applause.
Yes. Thank you so much.
Thank you for joining us. Thank you for joining us online. And if you have still questions, please stay with us or just share your opinion during the breaks. And have a good day. Thank you very much.